Hello, welcome to UConn Malnutrition Fair. My name is Isabella Helgeson, and I'll be presenting on neonatal nutrition. So, to begin, what is neonatal nutrition? Neonatal refers to newborns, and nutrition is the process of obtaining nourishment for health, growth, and survival put together. And neonatal nutrition is the vitamins and nutrients given to infants within their first month of life. Proper neonatal nutrition is very important, as malnutrition can result in poor growth and development, leading to pediatric malnutrition and long-lasting problems. The goal of neonatal nutrition is to ensure that the infant is continuing to grow properly through proper delivery of calories and nutrients. Another goal of proper neonatal nutrition is to avoid any imbalances in macronutrients. Infants grow relatively rapidly during the first 28 days of life, so their needs differ from those of children and adults. Neonates are particularly sensitive in this stage of life, as malnutrition can have effects on later development. Proper nutrition is essential for infants to reach their full potential. Improper fetal growth before birth and impaired growth after birth are both indicators for malnutrition. Preterm birth is a common cause of malnutrition in infants, as they are not fully developed and delivery of essential nutrients and hormones is impaired. Premature infants have higher nutritional needs of term infants. Birth weight is a well-known indicator of whether an infant may be possibly malnourished, but there are other tests done at birth, such as PKU and MSED, that check for proper metabolism of proteins and other nutrients. There are many ways nutrition is routinely monitored in infants, and we'll discuss a couple over the next few slides. For the purposes of the presentation as an introduction to neonatal nutrition, many of these tests have been lumped into a larger context of regular clinical practice, and there are more nuanced ways to perform these tests and diagnose malnutrition. We'll be discussing body weight, body composition, glucose and nutrient levels, and blood tests. This chart shows the relation of weight and gestational age, or how long the pregnancy was at time of birth. The color bands on the graph show how each birth weight is classified, either as LBW, VLBW, or ELBW. LBW stands for low birth weight and falls between 2,500 grams and 1,500 grams. VLBW stands for very low birth weight and falls between 1,500 grams and 1,000 grams. ELBW stands for extremely low birth weight and falls below 1,000 grams. LGA stands for large for gestational age, and babies are classified as this if their birth weight is in the top 90th percentile for gestational age. AGA stands for appropriate for gestational age, and babies who fall between the 90th and 10th percentile are classified as this. SGA stands for small for gestational age, and babies whose birth weight are in the 10th percentile fall in this category. It's important to note that while a baby may have an abnormal birth weight, this may be normal given the gestational age. For example, it would be expected that a baby born at 30 weeks would fall in the VLBW category while still being in that AGA category. Being small for gestational age can indicate a disorder during pregnancy that may have caused a deficiency of nutrients. For example, a common reason for low birth weight is intrauterine growth restriction, where an unborn baby doesn't have enough oxygen and nutrients to grow and develop, and can be caused by chromosomal problems or issues with the placenta, where nutrients are delivered during pregnancy. After birth weight measurements are taken, weight is monitored using similar graphs that compare extrauterine growth. Most neonates decline in weight immediately after birth, and the general time frame by which they should have returned to their initial birth weight is between 7 to 14 days. A delayed return to normal birth weight can also indicate malnutrition. Body composition can be measured in several ways, but a common, minimally invasive way is to compare various body measurements to ensure a proper ratio of fat, body tissues, and growth. It is important to note that birth weight does not indicate body composition, so it's important to use other methods of determining ratio of tissues. Most measurements require extensive charts to compare these values over time, as they can vary by height, weight, gestational age, sex, and other factors. Length is a good indicator of skeletal growth, which indicates proper nutrition if increasing at the proper rate. However, in clinical practice, it's hard to achieve a supine position to take an accurate measurement. Mid-upper arm circumference indicates the combined arm fat, and it's a good place for measurements as it's not easily affected by fluid status. It's also applicable to preterm infants, but in extremely premature infants, accurate mid-upper arm circumference measurements can be difficult to obtain due to avoiding compression of the skin and tissues while taking these measurements. Another method of using skin fold calipers can be a helpful tool in determining peripheral and central subcutaneous fat, an essential tissue in neonates. However, while there is a correlation between skin folds and body fat percentage, it's not completely accurate and requires further tests before malnutrition can be diagnosed. In addition, it's not always applicable to preterm infants as they can be delicate. The mid-upper arm circumference and head circumference ratio is proposed to identify intrauterine malnutrition at birth. It can be useful to identify symptomatic malnourished average gestational age neonates who are not able to be diagnosed based on birth weight. While body composition estimations are helpful because of their practicality in clinical settings, they are not always accurate, and further testing would be often needed to determine deficiencies in diagnosis. Preterm births tend to have different body compositions given the current methods of treatment, with more growth restriction, increased body fat, and decreased body lean mass. Neonatal hypoglycemia is when a plasma glucose level of a newborn is less than 30 milligrams per deciliter in the first 24 hours of life, and less than 45 milligrams per deciliter after the first 24 hours of life. It is the most common metabolic problem in newborns, and blood is routinely tested after birth for this. It can have many causes, but in most cases, treatment can control the glucose level. As a side note, neonatal hyperglycemia is when a newborn's blood sugar is too high, but that is related to an insulin deficiency and is not a nutritional deficiency. This chart shows the normal ranges for standard blood tests in neonates. HGV relates to hemoglobin, a protein in red blood cells, and a normal range is around 14.5 to 22.5 grams per deciliter. HCC is an abbreviation of hematocrit, which is a calculated value that represents the red blood cell count in the blood. Its normal range is about 48 to 69. Hemoglobin and hematocrit are interrelated, with the HGV being approximately 1/3 of the HCC value. Low hemoglobin and hematocrit can indicate malnutrition, as low iron is the most common cause of low blood cell count. MCV stands for mean corpuscular value, which is a calculated value that measures the average volume of a red blood cell. A normal value for MCV is around 95 to 121. A low mean volume can indicate an iron deficiency, and a high MCV can indicate a folate or vitamin B12 deficiency. EPO is a hormone produced in the kidneys that plays a key role in producing red blood cells. A high EPO indicates anemia. Well, this is a lot of information. To summarize, anemia and other nutritional deficiencies are commonly able to be diagnosed through a blood test. Many babies, especially premature babies, have some sort of anemia in the first month of life. A baby grows fast, and many times it can be difficult for the red blood cells production to catch up to the rest of the development. Another common cause of anemia in babies is because the body breaks down red blood cells too quickly, which is common in cases when the mother and baby's blood type do not match. This can cause jaundice at birth. Clinical observations can also be good indicators for nutritional deficiencies. Jaundice can cause yellowing of the skin and is common in premature babies because of an immature liver development. It can indicate indirect or direct hyperbilirubinemia, where bilirubin is not broken down and it builds up in the blood, giving the skin a yellow tone. A pale and washed out look can indicate many things, such as an iron or nutrition deficiency. Dermatitis, poor wound healing, and scaly dry skin can all indicate an essential fatty acid, vitamin A, or zinc deficiency. Flaky paint dermatitis can indicate a protein deficiency. These clinical observations can be helpful in diagnosing deficiencies as they are visible and give grounds for further testing. The acute and chronic complications of prematurity is why getting neonates adequate nutrition is so challenging but yet so important. Acute complications include respiratory distress syndrome, where fluid builds up in the alveoli of the lungs, apnea, where breathing slows or stops, poor temperature control, where temperatures can't be regulated properly, intraventricular hemorrhage, when there is bleeding in the ventricles of the brain, retinopathy of prematurity, where blood vessels in the retina stop growing and then grow abnormally, potentially causing blindness, and anemia, jaundice, and infections. Some chronic complications of prematurity and malnutrition are cerebral palsy, which affects ability to move and maintain balance and posture, impaired cognitive skills and behavioral and psychological problems, asthma, feeding and digestive problems like reflux and oral aversion, and vision problems like retinopathy of prematurity. While we unfortunately don't have enough time to go into each amino acid, I would like to point out PKU and maple syrup disease, mentioned earlier in the presentation. PKU is a disease where the amino acid phenylalanine isn't broken down by the body. The U.S. tests for it at birth, but many countries do not. Maple syrup urine disease is genetically inherited, where certain amino acids cannot be broken down by the body, and it's normally diagnosed in infancy. As we can see in the chart, it leads to higher levels of valine, leucine, and isoleucine in the urine, giving it the darker color as seen in the picture. Both disorders share the commonality that a specific amino acid cannot be broken down in the body. These disorders, while rare, can cause serious problems for a neonate, and they are normally tested for at birth. There are a few standout methods of treating neonatal malnutrition that we will discuss. We will talk about the role of parenteral nutrition and enteral nutrition in the treatment of malnutrition, and the importance of caregiver education, as caregivers play a very important role in the treatment and prevention of neonatal malnutrition. Especially for premature infants, around 80% of the minerals are accrued in the bone during the third trimester, and premature infants do not have this critical time in an intrauterine environment to develop. Thus, it's important to match the intrauterine accretion rates through an extrauterine environment nutrition interventions, which is extremely difficult. Parenteral nutrition, or PN monitoring, is a method of delivering nutrients through an infusion system, typically through an intravenous vein. It's used to treat neonates that cannot be fed orally or cannot gain proper nutrients through other methods. Diagnostic tests allow the physician to determine the initial levels of the deficient macromolecule, set a goal, and then deliver through the infusion system at appropriate increments. PN is considered the standard of care for extremely premature infants, as it helps avoid negative nitrogen balance, it promotes weight gain, and allows for the gradual increase in milk feeds. It's generally agreed that infants less than 32 weeks gestational age or with a birth weight of less than 1,500 grams will be started on PN after birth and will receive it for 1 to 2 weeks as enteral feeds are advanced. It's often referred to as a bridge PN, and as it serves as a bridge to enteral feeds. This chart is an example of a recommendation for physicians treating neonatal malnutrition. Initiation is the starting point of the neonate, so their intake levels of the macromolecule at the start of treatment. Advancement is by how much the intake will be increased by, in this chart's case, each day. The goal is the intake level of macromolecules that will hopefully be achieved. The neonate column indicates the particular nutritional problem these treatments could be required for. For example, in extremely low birth weight infants, amino acid intake may be increased to help the growth of the infant. Enteral nutrition is always preferred over parenteral nutrition. Enteral feeds should be started as soon as medically able. Ideally, this is within the first 24 hours of life. Early feeds, while evaluating feeding tolerance, has been shown to improve intestinal development, improve feeding tolerance, promote earlier achievement of full feeds, and decrease problems related to PN. Human milk is typically preferred if possible, and the levels of nutrients found in human milk are used as a guideline for formulas and are considered the gold standard. When mother's milk is not available, it's recommended to use pasteurized donor human milk and then premature formula. Nutritional needs of the preemie do exceed the content of human milk, however. Unfortified milk can be associated with poor weight gain, nutritional deficiencies, and a reduction in growth. In premature infants, specific concerns are proteins, calcium, phosphates, magnesium, sodium, zinc, vitamin D, C, E, K, and many other micronutrients. Human milk fortifier can be added to breast milk to better meet these needs. Formulas can also be customized for neonates' nutritional needs. However, for preterm neonates, this is not always an appropriate option for the treatment of nutrition. They do not have the reflex for swallowing until 32 to 34 weeks and may have impaired digestive development. For this reason, using formula and enteral feeding is not standard and is cautiously used in treating extremely premature infants. However, in order to prevent gut atrophy, it's common to use a sort of priming feeding. These are also called tropic feedings or minimum enteral feeds, or MEFs. These are small feedings that range from 1 to 25 milligrams per kiloliter per day of either human milk or formula to help promote gastrointestinal tract maturity. They can serve as supplements to parenteral treatment and are used depending on the neonate's response to MEFs. This method of using MEFs to supplement parenteral treatment is often preferred for extremely malnourished neonates, as it minimizes loss of normal and gastrointestinal function without overwhelming the digestive system and allowing for necessary nutrients to be delivered in controlled quantities. Education of caregivers can be helpful for the treatment of neonatal nutrition. However, the education of the mother before birth is crucial in preventing neonatal malnutrition. By going to checkups before birth, disorders that may affect baby's nutritional status can be diagnosed and treated as early as possible. Prenatal nutrition is a whole other subject, but there's a strong link between the two. Studies show that in communities where neonatal education is limited, babies on an average weigh less than the babies whose mothers were educated on neonatal nutrition and had proper prenatal care, showing the importance of education in the prevention of malnutrition. So, ending on the topic of education, I hope that you learned something about neonatal nutrition. Thank you for listening.